It's a great pleasure for me to be here in this wonderful company. My job is to talk about something that requires about 1.5 days, and I got 30 minutes. So you understand that there will be kind of advice for you. Namely, I turned into the RSNA these URLs. Actually, at the end, it's going to be on my computer. You can copy it. I don't want to waste time now. If you have a computer here and you punch in this one, you got hundreds and hundreds of slides. I give you an enormous amount of material because I'd like you to take home the message. The question is how to find breast cancer when it is still early or small. If you ask me that question, you actually ask two questions. What does it look like? And on the mammogram, is there any special region where I should really look carefully because most of the cancers are there? You certainly remember when we were screening for tuberculosis. Then there were the two segments we carefully looked at, segment 2 and segment 6. Most of the tuberculosis was there. So your second question really is, after we manage this, answering this question, what to look for and where to look. And I'm going to be able to go through the principles, but not all of the examples, because there is no time. And certainly because this lecture is about perception, so there won't be any comment about calcification, because white specks you can see on the mammogram. Calcifications are not a perception problem. If it is, then we have a problem. But it's a differential diagnostic problem. The real problem which you are facing and I'm facing in every second case is asymmetric density on the mammogram. There is a radiopaque density here, and on the corresponding area in the other breast, there is no such density. What am I going to do? Of course, the wrong approach is to always think about cancer. Cancer is a rare disease. Out of 1,000 screened women, only 5 or 7, less than 10, have it. So what are you going to do when the 995 come by? My suggestion is try to think and also feel empathy with the women. Think about normal fibroglandular tissue. And for that, you really have to know the reflection of the three-dimensional histology, namely the 4 basic building blocks. One of them is the 1 to 1.5 millimeter sized terminal ductal lobular unit. We can see it separated from the other because there is fat. So number 1, number 2 basic building block, and if we are lucky, then we also see ducts and their branches, and here is duct and branch, and they are also separated by fat. Now, if I see 3 out of 4 basic building blocks, and of course the 4th one is what we all dislike, is the homogeneous ground glass-like concave contoured fibrosis. If we see 3 out of 4 then basic building blocks, then you are looking at normal fibroglandular tissue. If you have 15% callback rate, then you don't know what the normal looks like. Problem starts here. Non-specific or equivocal asymmetric density. I'm looking for TDLUs and I'm looking for duct and I don't see them. Or I see only 2 out of 4 basic building blocks. There are 2 subtypes here. One is without architectural distortion. The other one is with architectural distortion. And I think this is much easier. If you miss a cancer, trust me, this is why you missed it. And then the third option of analyzing asymmetric densities is a definite pathologic lesion. Here is a central tumor mass, straight speculations. It is a cancer, and there is no such thing in the corresponding area of the other breast. Or a circular lesion, may it be a fibroadenoma, cyst, or papilloma, or cancer. So, dear colleagues, basically, if you want to read a mammogram, you really have to be familiar with and constantly searching for the basic building blocks. Normally it looks like this in a schematic drawing, or when it's adenosis, then it's larger, or this is what we certainly dislike, fibrosis. And in reality, this is what we are imaging, the three-dimensional subgross histology image. And when you put an X-ray tube above it, as we do it, and we call it a mammogram, this one, the milk factory, measures about 1 to 1.5 millimeter in size. Why can I see this one separated from this one and that one? Because there is a fat among them. And here we see the ducts as well. This is normal. This is normal too, but it's a variant, namely a high-risk adenosis pattern. And this is what we all fear. That is, yes, the TDLUs are there, the ducts are there, but we cannot see them because of the covering dense fibrous tissue. By the way, I'm showing to you right now the 3 subtypes of dense breast. Unfortunately, we don't have time to go into this, but this is the most frequent but the lowest risk. This is high risk, 12% of all women, and this is high risk. About 20% of women with dense breast run a high risk of getting a breast cancer. So don't tell your patients that because they have dense breast, they run a high risk of getting a breast cancer. We radiologists have a big problem in finding a cancer hiding in this dense tissue. So just as a very quick introduction, let's look at how you analyze asymmetric density. There is an asymmetric density because this one is missing from here. And now I'm going to analyze it by looking at on the digital mammogram, magnified picture, and I always think in color. So I'm saying, is there any TDLU? Yes. Different sizes? Yes. This could be, the smaller could be this one, the larger could be this one. So I got one basic building block. And do I see fibrosis? Yes, it's here. Very thin, fortunately. Do I see a duct? Yes. Do I see fat? Actually, I see 4 out of 4. And it's a large density. It's a normal fibrogranular tissue. And before I sign out a well letter, then we have this picture as well. And now you understand that this is adipose tissue, this is radiopaque fibrosis, and we already talked about the TDLUs. So welcome back. Next screening. Was it asymmetric density? Yes. But it was normal fibrogranular tissue, just like here. There is no such density here. So then you look at this and you think in 3D and you say, this is actually a terminal ductal lobular unit. Any of these. And this one is a duct. And this is fat. Thanks very much. This is normal fibrogranular tissue, and because of its location, we call it accessory breast. Next step. Non-specific asymmetric density. Without architectural distortion, we are in trouble. Asymptomatic woman. Do you see an asymmetric density? Yes. Actually, how you can describe this is asymmetric because there is no such density here. And it has convex contour. Dear colleagues, the normal fibroglandular tissue is always concave. This is pregnant. It must be an excess amount of tissue. Now, whether it's fluid or cancer or fibroadenoma, that comes later on. But this is already a callback. It's a non-specific asymmetric density because I tried to find TDLUs and ducts in it, and there aren't any, and because it's convex, and because it's in the wrong place. You're going to hear immediately 61% of the cancers are here. So this is clearly a callback case. Even if it doesn't look like cancer, you know that the baby phase of the cancer is a non-specific asymmetric density. If you let it grow a little bit, then it becomes a very clear malignant lesion, and then now you know that this is a cancer. You work it up, solitary lesion, you put the needle into it, you got malignant cells. This has, however, an interesting story. This was very important to find because this is actually a basal cell carcinoma, smaller than 10 millimeter, and this is a surgical disease. Now, this patient, just like your patients, are getting the radiation and the chemotherapy and whatnot, and so she comes back for 7-8 years regularly. 8 years later, this was before the first surgery, and now this is the 8th year. Again, she developed exactly at the site of surgery a non-specific asymmetric density, because it doesn't have the terminal ductal lobule in it, it doesn't have duct, and it is convex, and it's in the wrong place. And then you go for it, and of course it's a carcinoma. And then you do what you have to do, hand-eye coordination, you get the cancer cells, you take it out. Surprise, surprise, despite chemotherapy and so on, the same disease came back. This is a basal-like carcinoma. Now that was an example for the non-specific asymmetric density without architectural distortion. Here comes with architectural distortion. And here we have a very important and very logical algorithm. First of all, you really have to ask the patient whether she had trauma. Hopefully she doesn't have, so traumatic fat necrosis out of the picture. Second, you have to palpate. You, not the referring physician. You have to palpate. And if it's not palpable, then you might think that this is going to be the only benign option, namely a radial scar. However, if she has a huge breast, in the middle of the breast there is a non-palpable architectural distortion, it still may be carcinoma. However, what is important here is that, let's say she has a palpable lesion, and they usually call it thickening. Unfortunately, you really have to think about two very mean malignant subtypes, the neoduct genesis and the so-called classic invasive lobular carcinoma. Here it is in front of you. I'm sure you already found the architectural distortion. It's here. And these are nothing else but radiating, proliferating ducts. It's actually a radial scar. But in another case, you see here there is a huge architectural distortion, and that was palpable. And this is asymmetric density because there is no such disease here. And that looks like this. A sad story, the diffuse carcinoma, which accounts for most of the breast cancer death nowadays. And then the beautiful comparison between imaging and large section histology. You see cancer here in the nipple and in 2/3 of the breast. This is the reason why most of the breast cancer patients die from this disease. So now, what to look for? I just told you, namely, non-specific, equivocal asymmetric densities and definitive pathologic lesions. And the definite pathologic lesion is either a circular lesion or stellate lesion, architectural distortion, and calcifications. Please keep in mind that calcification is the least important thing in mammography. Quantitatively, it's less than 30%. This is, if you really want to save lives, this is what you have to find. Non-calcified stellate and circular lesions. And out of those, which one is more frequent? The stellate lesion or the circular? Fortunately, the stellate lesion, because this is a low-grade lesion at the time of detection when we find it. For example, here are a lot of baby cancers, that is 1 to 9 millimeter. I classified 376 of them. 50% were stellate lesion, 20% circular, and the calcification is on a back seat. Science, if we really want to go back in time and get rid of the advanced cancers, don't chase calcium. Of course, we all take care of calcium. That's not the point. But if you decrease mortality in your community by 50%, then only 5% of the 50% is originating from taking out all cancers, or all calcifications. 95% originates from finding the non-calcified stellate lesion when it is really a baby and it's still localized to the place of origin. And here is science again. Thousands of cases, 20-year follow-up. That's the goal. So answering your first question, asymmetric densities. What am I looking for? Already stellate lesion, circular lesion, and what is very difficult is the non-specific asymmetric density. And of course calcifications, or the combination of them. Now I owe you the answer to this question. Where? Is there any special region here which has most of the carcinomas? Yes, there is. If a woman is standing in front of you and you just draw a horizontal line over the nipple or nipples, then 80% of the breast cancers are in the upper hemisphere and 20% in the lower half, leaving about 1 to 2% to the retroareolar area. But you already made the calculation here. 70% in the lateral half and 30% in the medial half. Please keep this in mind, because that is going to be extremely important in the continuation of your everyday practice. For example, you see something in the CC projection, but you don't see it on the medial lateral oblique projection, and you ask your technologist, find it. Certainly, there is an 80% chance that it's in the upper half. Well, this also leads us to this conclusion, which we have known for 100 years, that the upper outer quadrant has most of the breast cancers. Yes, but the technologist was kind enough to turn the patient and squeeze the breast where is the upper outer quadrant. Dear colleagues, this is important. Namely, the upper outer quadrant is between these two lines. Namely, you draw a line along the pectoral major muscle, and then you draw another line about 3-4 centimeters from there. And this is the upper outer quadrant where you're going to find most of the breast cancers. You send me 2 medial lateral oblique projections for consultation, and I'm just sweeping this area, which is going to have what? Most of the stellate lesions. And out in the sky, a parallel path which has most of the stellate lesions, the stars, we call the Milky Way. Dear colleagues, this is where you look for stellate lesions, circular lesions, and non-specific asymmetric density. It does not need to be a ready cancer. You find it earlier if you really call back those who have these number of basic building blocks. That was number one, the most important. Second, that is, I'm going to share with you 4 regions in the breast which has most of the breast cancers, and the medial half is the next. That is, the medial half is supposed to be entirely fatty replaced. Whenever you see a non-specific asymmetric density, circular lesion, stellate lesion, you strike. And you're going to find about 30% of the cancers. May look like this, maybe 2, with a bridge in between, and in the bridge there always is cancer. The third one is the retroglandular clear space. But then you could ask the question, yeah, the accessory breast localized here or localized there can be projected here. Yes, but don't forget, those are specific. That is, you are going to see the TDLUs, the ducts, and the concave contoured fibrosis. We are talking about non-specific asymmetric density localized in this retroglandular clear space that must not contain anything else but fat. That's why we call it the no man's land. And then the last one, the retroareolar area. Very tricky. We have to train our technologists to place the nipple in profile, which is quite an art and very difficult. And about 1 to 2% of the cancers are localized here. But it's a very important site because they break themselves easily into the sappy plexus and carry the cancer away. So that's why male breast cancer is more fatal than female breast cancer in general, because men usually have small breast, and the cancer is practically always behind the nipple. Well, we have the problem with the dense breast. That is the pattern 1, 4, and 5, and it may be so that the cancer is bulging out of the contour, easier to find, or it actually retracts the contour. You see how nice, harmonious arcade-like the contour here is? This is what we can call tense sign. You don't readily see the cancer, but it's there. Don't accept any straight line in the breast. And then, of course, the architectural distortion is usually within the parenchyma. Very important message. Don't compare today's mammogram with yesterday's mammogram, but the next to last. Then you are going to be able to perceive the change. And don't ever forget that after having found one lesion, don't stop looking. There may be another one. It's very frequent. Multifocality is very frequent. Actually, only 40% of the cancers, breast cancers, are unifocal. And of course, you really have to have very, very good contrast, proper positioning, and so on. Because if the pectoral major muscle is going to end up in here, then I'm going to miss a significant portion of the Milky Way. I want to see. This is all a risk area. I want to see all the way down, and then the abdomen takes over, and how ambitious we are. The nipple should be in profile. We should see the lymph nodes. Very difficult to do. Lymph nodes. Quite an art. We don't have time on this. Here is the first example that shows what a mistake we can make. You can be the best mammographer in the world. You are going to miss the cancer because it's not on the mammogram. You see, the pectoral major muscle should have been like this here. And 5 minutes later, should have looked like this. 5 minutes later, you have another picture, still not perfect, but this case has a cancer. Improper positioning, proper positioning. And mind you, there will be 7 centimeter area here with cancer in situ. Previous mammogram didn't have it. And this is not a proper positioning either, because I don't see the tail end of the fibroglandular tissue, and that's exactly where the cancer is. Well, you have to resort to
Good afternoon, everybody. Well, Dr. Tabar has given me a nice segue into my talk. The title I was given was How to Get the Most Out of Breast Ultrasound. And I have to thank my colleagues who have given me material today for presentation. You've seen my disclosures. So what I want to do today is to review the current uses of breast ultrasound and to focus some time on the supplemental cancer detection yield of screening ultrasound in trials to date, including automated whole breast ultrasound, and in particular to stress the risks of false positives when we use ultrasound for screening and how to deal with them, and the low PPV for biopsy in lesions that we find only on ultrasound. I want to give a brief introduction to elastography and a glimpse into the future with ultrasound-based fusion imaging. So we know that ultrasound is the go-to tool for assessing palpable masses, whether or not they're visible on a mammogram, but especially when they're inconclusive on a mammogram. If you have a mass on the mammogram that is a hyalinized fibroadenoma, or even a typical cancer, you don't need a diagnostic ultrasound to help you make your diagnosis. You might want to do an ultrasound to biopsy that cancer, but you don't need it then. The ultrasound really kicks in when the mammogram is inconclusive. We use ultrasound, of course, for non-palpable masses, the ones we find on screening mammography, but also now with ultrasound screening, and for second look ultrasound for masses seen on MRI. We use it occasionally for evaluation of implants. And it's absolutely the preferred method to guide intervention. If you can see a lesion both on ultrasound and on mammography, and you've got the choice to biopsy it either with stereotactic guidance or ultrasound guidance, ultrasound's the way to go. It's faster, cheaper, more comfortable, and doesn't use ionizing radiation. We use ultrasound, of course, to help with cancer staging when we're asked to find additional cancers and to identify and biopsy axillary lymph nodes in patients with a newly diagnosed breast cancer. And in that way we can help with treatment planning. We've started using it for supplementary screening and for investigation of nipple discharge. So ultrasound's a really important tool. And the basics, and I'm not going to go into the details of scanning, but I just wanted to review. It's important to be using the right transducer, typically a high megahertz linear array transducer. You want to make sure your gain and your focal zones are set properly, otherwise you can be right on top of a cancer and not even see it. It's under your nose because you don't have the settings properly adjusted. The TGC you can set manually, or a lot of the newer machines do it in an automated fashion. And it's very important that you do all of those. Once you do and you find your lesion, you have to correlate with palpation. If the patient is coming to see you because she has a lump, you get her to show you that lump, show you where it is, and you examine her. And then you put your probe on top of that lump and make sure that the mass you're showing on your ultrasound corresponds to her palpable lump. If you see the mass on the mammogram, you have to know how to triangulate from the mammogram where in the breast to start to look with your ultrasound. And similarly with MRI. And for this reason, it's particularly helpful if the radiologist doing the breast ultrasound also does mammography, and in the case of second look ultrasound also does MRI, because you really have to understand the subtle nuances of those other modalities to make the ultrasound work for you. Once you find your lesion, there's some post-processing you can play with to help you distinguish the features of a lesion and distinguish whether it's benign or malignant. Speed of sound imaging, extended field of view is helpful when you want to show the relationship of the mass to the nipple, for example, to send a picture to your surgeon. And of course we use Doppler as well. And once you use all these tools, you can get these exquisite images and make your proper diagnosis. But what I wanted to do is bring your attention to this wonderful article earlier this year, which goes over all the basics of ultrasound, this year's radiology, and this is the group from Yale. It's a wonderful article, so I'm not going to spend a lot of time on the basics. What I wanted to start focusing though on is using ultrasound as a screening tool. And before we can even talk about ultrasound for screening, we have to understand the basics of screening for cancer. We need a test that will detect the disease earlier so you can alter the natural history of the disease, and in so doing reduce the mortality from the disease and the morbidity from the treatment. Earlier detection will allow breast conservation and less harmful treatments. So when the USPSTF, the United States Preventative Services Task Force, tells us that we have to balance the harms with the benefits, we want to minimize the harms and increase the benefits of screening. And when we're doing a screening test on large numbers of women, we have to make sure that healthy women will not be harmed, and ideally the test should be widely available, cost-effective, and well tolerated by patients. Dr. Tabar has taught us that mammography is the only screening test to date which has been shown to reduce mortality from breast cancer. Dr. Tabar's work in Sweden and multiple other randomized trials have shown reduced mortality among women invited to screening, but in fact that underestimates the benefit because of non-compliance. Not all women invited will attend. In fact, if you look at the women who actually attend for screening, mortality reduction is in the range of 40%. Now, some opponents of screening will say, well, we don't have to be that aggressive with screening anymore because the treatments are so much better. And again, Dr. Tabar has shown us that that's not true. These lines represent women in different decades. This is the late 50s to late 60s, late 60s to 70s, and you can see those survival curves are not that much different. But these two different lines represent women in the same era before, these were before screening was introduced, and this was after screening was introduced, but the purple triangles show you women who didn't have screening compared to women who did. And don't forget, women who have a cancer diagnosed because they show up with a palpable lump get state-of-the-art treatment. So the split between these two cumulative survival curves is based on the fact that these women had screening, so that the difference in mortality is more significantly based on the screening rather than the treatment. Yes, we have better treatment, and yes, women survive more now than they did when those treatments weren't around, but screening is the key here. And the decrease we see in mortality among screened women is almost entirely attributable to the decrease in size of the cancers that we find on screening, and across 7 randomized trials of screening, mortality reduction closely paralleled reduction in node-positive cancers. So the bottom line is screening is only going to work if we find small node-negative cancers, and that's what we can do with mammography. Now, I'm giving you an ultrasound talk, though, and we're not going to have a randomized trial, I don't think, of ultrasound screening, but we can use surrogate endpoints. So we know that we want small, node-negative cancers, and we know that the natural history of breast cancer is known, and it doesn't vary by the method of detection. So if we can find small node-negative cancers by any other modality, and today I'm talking about ultrasound, we should be able to achieve that same mortality reduction. The subgroups of women who do not benefit as much from mammography are those with dense breasts, because the sensitivity is reduced, the cancers are masked. So in those women we should consider supplemental methods of screening or more frequent screening or both. And any method that detects small node-negative cancers will provide that additional reduction in mortality. The overlapping subgroups are women at high risk and women with dense breasts. Now, radiologists are pretty good. Dr. Tabar has just shown you, here's your typical spiculated cancer, and we're pretty good at finding cancer when we can see it, and this cancer is easy to see because it's surrounded by fat. But reading mammograms is not like reading a chest x-ray. I mean, chest x-rays pretty much all look the same when they're normal. There's the heart, there's the ribs, etc. But this is a normal mammogram in a woman whose breast is almost entirely fat, and you can see it's largely this gray color. But this is a normal mammogram too in a woman who has what we would call scattered fibroglandular densities. You can see there's white stuff here. And what color was that cancer I just showed you? It was white. So if this woman's unlucky enough to get a cancer that's in the area where her normal dense tissue is, she's out of luck. We're not going to see it on her mammogram. This is also a normal mammogram, but she has what we would call heterogeneously dense breasts. And finally, the extremely dense breast, or as Dr. Kopans calls it, the hide-a-truck breast. So our mammographic sensitivity decreases as breast density increases. And women with at least 50% parenchymal density on mammography make up a significant proportion of the screening population. Almost 60% of women in their 40s, and percentage is declining as we look at older age groups. We know that women with greater than 50% parenchymal density, especially in younger women, accounts for a significant portion of risk. 26% of all cancers are in women with dense breasts. 50% of interval cancers, the cancers that are diagnosed clinically after a negative screening mammogram within in less than 12 months, and almost a third of cancers detected after 12 months after a negative screening mammogram. But as Dr. Tabarz also mentioned, not only is dense breast tissue an issue because it masks cancers and makes it harder for us to see them, dense tissue is an independent risk factor to the order of 4 to 6%, and 4 to 6 times. And we have heard many lectures at this RSNA about breast density and its significance. Now, in the early 70s, there were attempts made to build an ultrasound machine that would scan a whole breast. And this was a prone table where a woman's breast was suspended in water, and these transducers were below the water scanning her breast, but they were low frequency. This was a supine scanner. The woman would lie on her back, and the transducers are up here, and the water bath was encased by this plastic bag, which would then drape over her breast. And guess what? It didn't work. It didn't work because they had 3.5 and 5 megahertz transducers. The 10 megahertz transducers, which were the first of the really high-frequency transducers, were introduced in the early to mid-80s. And so you can tell this is a really old mammogram, but this was the very first case where I found a cancer unexpectedly on ultrasound. This was a woman who came because she had a palpable lump in her left lower outer quadrant, and there's the cancer in her left lower outer quadrant. It was palpable. They didn't have breast fellowships in those days. I'd done an ultrasound fellowship. And so, as was my habit, whenever a woman came for a breast ultrasound for whatever indication, I always scanned the rest of that breast. And in this woman, I found a pretty good sized mass. You can see it taller than wide, or we would now say anti-parallel orientation. Needle biopsied both of them, and they both turned out to be cancer. And so this woman, who was anticipating having a lumpectomy for her palpable cancer, ended up having a mastectomy. Now, we reported our data on screening, and ours was a retrospective study of just scanning the ipsilateral breast in the mid-90s, but soon after multiple other single investigator publications came out with, look at that, a fairly similar pickup rate for cancer. So these were cancers that were not palpable, and they weren't visible even in retrospect on the mammogram. In the early 80s, Wendy Berg proposed a trial of screening breast ultrasound, which has been subsequently performed and published as the Akron 6666 trial. And what they did was almost 3,000 women at 21 different sites in USA and Canada. Each of these women had 3 annual independent screens, both with mammography and physician-performed ultrasound in randomized order. After 3 rounds, women were offered MRI. Only 612 of the 703 chose to have the MRI, and then the reference standard was either positive histology and 12-month follow-up. These were not all comers. These women had to have at least 25% fibroglandular density on the mammogram. They had to be screening patients with no palpable or clinical breast abnormalities, and most were at elevated risk for breast cancer. So this was not an average population. Furthermore, all of the investigators were qualified. They had to have experience reading mammography and doing breast ultrasound, and they brought them in and tested them. They tested their mammography interpretation. They actually had live patients, and they knew how many lesions each patient had in her breast, and these investigators had to scan these women and see if they could find all the lesions. All of these women had 2-view mammography, and in those days, about a third of it was digital and 2/3 was still film screen. Now, the technique that they made the investigators use when they went back home to do these screening patients was quite extensive. They had the patients positioned as we normally would, but they had to scan the whole breast transverse and then the whole breast sagittal. So they increased the necessary time, I think. And they had to use appropriate transducers. Any lesions that they saw other than cysts, they had to image both with and without spatial compounding and Doppler in orthogonal planes, and they had to take a minimum of 1 image in each quadrant and behind the nipple, even if there was no lesion. So they kind of dragged out the test a little bit. And this is a case that Dr. Berg has given me. This is not the cancer in this heterogeneously dense breast, but rather this 8 millimeter grade 2 invasive duct carcinoma that was only seen on ultrasound and not even retrospectively on her mammogram. So the Akron trial showed in the first year, where you're doing the prevalence screen, 5.3 cancers per 1,000 women screened, and in the second and third years they kept finding more cancers, about 3.7 cancers per 1,000. So overall, 4.3 cancers per 1,000 women screened over 3 years. And here's the good news. 94% were invasive, and the median size was 10 millimeters, and 96% of those staged were node negative. So that's what we want to find, the small invasive cancers. We don't want to find the low-grade DCIS. For the women who went on to have the MRI, and as I explained, 42% of the eligible women declined the MR, they found on top of all that, they find an additional almost 15 cancers per 1,000 women screened. But don't forget, this was a high-risk, an elevated risk population. So breast ultrasound passes the test for yield in terms of high cancer detection rate. It's pretty much the same as what we're finding on mammograms. We're doubling our cancer detection rate if we do women in this population. Now, it does have a false positive rate, and the question is, how well is that tolerated? Also, some women are recalled for short-term follow-up by BI-RADS3, and a lot of women get biopsied. If you're dealing with a high-risk woman and you're doing an ultrasound and you find a lesion, it's sometimes very difficult to talk her out of a biopsy. If mom died of breast cancer and you're doing her very first ultrasound, in fact, it's worth spending quite a bit of time explaining to a woman before you do that first screening ultrasound. Look, you've got stuff in your breast that's been there 20 years. It's our first opportunity to see it. Just because I find something doesn't mean it's cancer. We also have to look at whether finding these cancers actually decreases the interval cancer rate down the line. So with the Akron trial, it significantly increased the rates of false positive, 7 to 8% absolute increase in recall rates for incident screens, 3% absolute increase in short interval follow-up, and 5% absolute increase in the number of women biopsied. And for the lesions that were biopsied only because they were seen on ultrasound, only 10% of them turned out to be cancer, and we're used to working in the 30% range for mammography. So there is a risk of false positives doing screening ultrasound, but in the Akron trial, the risk of a false positive was lower for women with a personal history of breast cancer than in women without, both for the ultrasound and the MRI. So when might you want to consider using ultrasound for screening? Well, we know that the ACR recommends that women at greater than 20% lifetime risk of breast cancer have annual MRI, but we know that not all women want to have MRI even when it's suggested, and so maybe some of these women would be amenable to having ultrasound instead. Perhaps women with extremely dense breasts or heterogeneously dense breasts with other risk factors like a personal or family history of breast cancer or previous atypia on a biopsy. The advantages of ultrasound, of course, is the equipment's widely available, patients like it, it's well tolerated, it's relatively inexpensive, and it doesn't use ionizing radiation. And even better, once you find that mass, it's fairly easy to do an ultrasound-guided procedure. So if you're going to do it, as I said, women should be informed ahead of time of the increased risk of false positives, and implementation requires technologist training and validation. We actually have our technologists do the screening ultrasounds now, but you really need to train your tech well so you have complete comfort in them doing the examination. Otherwise, physician-performed breast ultrasound is completely reasonable. It just takes time. And there are trials ongoing right now to evaluate mortality reduction. Now, you can't just put your head in the sand and say, ooh, I don't want to do screening breast ultrasound. It is coming to a state near you. The organization RUDense.org was started by Nancy Capello, who's a bright woman who was diagnosed with breast cancer and told by her doctor that the reason it didn't show up on her most recent mammogram was because she had dense breasts. And she said, wait a minute, you know I have dense breasts and nobody's told me about that, and nobody's told me that maybe I could have had my cancer found sooner with ultrasound. So this is a grassroots organization that has effected quite a bit of change. There is now legislation passed in 13 states, with 17 states considering it, to inform women of their breast density at the time of the mammogram. The pink states are the ones that have enacted the law. The blue states are working on a bill, and the bill has been introduced, and only 3 states include the requirement that it be covered by insurance. But be aware that 40% of U.S. women live in states with mandatory breast density informed laws, and that it's going to be introduced both in the federal Congress and Senate, and the FDA is considering an amendment to MQSA for a national requirement for breast density notification. Connecticut was the first state in which there was a breast density informed law, and so they're way ahead in being able to report on their experience. They did a retrospective chart review that's been published, 72,000 screening mammograms and almost 9,000 screening ultrasounds. 9% were BI-RADS 3 density, 5% were 4 or 5, and of those recommended to undergo biopsy, out of 429 women, 418 were performed and 28 cancers were found with 1 false negative. So they had an additional yield of 3.25 per 1,000 cancers. Now these are not high-risk women, these are just women with dense breasts. Normal mammograms, no additional risk factors, with a negative predictive value of 99.9%, which is kind of nice for women to know. The only downside was the positive predictive value, as I explained, is low. Ultrasound is always being criticized for being operator dependent, and the time to perform the ultrasound examination on the breast is an issue, especially with problems with manpower. But as I explained to you, the Akron protocol probably exaggerated the requirements, and one of the papers that I showed you from Dr. Tom Kolb in New York, he claims he can do a bilateral handheld whole breast ultrasound in 4 minutes. Now, one of the solutions to this problem is automated whole breast ultrasound, and there are a couple of vendors that have these machines. They use a large footprint probe with 2 to 3 acquisitions in about 15 minutes. So the technologist puts lotions on the breast, holds the probe against the breast, and the images are acquired. The nice thing is that it uncouples the acquisition and interpretation part of an ultrasound. If you're doing a handheld examination and you come across a lesion, you stop, you take pictures, you think about it, you turn your harmonics on and off, and so on. So you're interpreting it at the same time as you're acquiring it. When you do an automated, all the images are collected and they're viewed later, just like we do when we're reading screening mammography offline. A typical examination will be over 3,000 images, and they're displayed transverse, sagittal, and coronal, and the 3D volumes are displayed as 1 to 2 millimeters thick because that's the typical diameter of the TDLU. When you see a lesion in the coronal plane, you can then put crosshairs on it, which will display it in transverse and sagittal. And when you first look at these coronal views, they're like you're looking at the moon. They don't look like ultrasound like we're used to thinking of it. But the big bonus is they really bring out architectural distortion. So once you find something with the automated, typically you would bring the patient back and do a handheld. And can you see this is a coronal view? Does that look like, I mean, this is what we're used to looking at. Now you're looking at the breast like this, but it really makes the lesions pop. And here's a case that I was given by Dr. Jacobs, this heterogeneously dense breast, no abnormalities, but on the automated ultrasound you can see this hypoechoic mass and little spiculated margins, and here are the transverse and sagittal views. There has been a few publications. This is on an older type scanner, but it was done 8 facilities in 4 states, published in European Radiology, well, whatever. Over 6,000 automated whole breast ultrasound examinations in almost 4,500 women. The mammograms were routine in 5,000 and annual asymptomatic diagnostic exam in almost 1,500. They found 57 cancers in 56 participants. Look at this. They doubled the cancer detection rate. Their cancer detection rate on mammography alone was 3.6 per 1,000 and doubled it when they used the ultrasound. One thing interesting about this study was that the PPV for biopsy was pretty high, 38%. 90% of the cancers were less than 2 centimeters in size, but the number of invasive cancers less than 10 millimeters tripled. That's what we want to find, small, invasive, node-negative cancers. And this technique required a 15 to 20-minute acquisition time and a 5 to 7-minute interpretation time. Another big study that's been done, which will be published soon, Dr. Brem was kind enough to share the data, was of 15,000 women. They actually stopped the study early because they were finding more cancers than they anticipated. And out of this large prospective clinical study, they did a retrospective reader study. This was from 13 sites sites across the United States. And they looked at 200 breast screening cases, of which 164 were included in primary analysis. They found 112 cancers in the clinical trial. 30 of them, or almost a third, were detected by the automated breast ultrasound, and they had pathology available for 25 of those cancers. 23 out of the 25 were invasive, only 2 were DCIS, and again, small. The mean size was 13 millimeters. And this is a case from Dr. Brem. This is a heterogeneously dense breast with no abnormality noted. And here it is on the automated coronal scan. You can see the small smiculated mass turned out to be a grade 2 stage 1A invasive breast cancer. And what I also want to stress is that another benefit of doing the coronal imaging, not only does it enhance the spiculations, but if you're looking at a small cancer on a handheld study, let's say it's a 3 millimeter cancer and you're moving your probe and you blink, you might actually miss the cancer. On a coronal, not only do you see the hypoechoic mass, but as you're scanning coronally, say towards the chest wall, you get more opportunities to see it because you see the posterior acoustic shadow. You see that on all the slices posterior to it. So that's another benefit of the coronal. And here's that same cancer on a handheld. So as a result of the increased sensitivity of the adding ABIS to mammography, the ABIS has been FDA approved for women with dense breast parenchyma who've not had previous breast intervention. The Italian group did something even more interesting. They looked at whether finding these cancers on ultrasound would indeed decrease the interval cancer rate later. And they did a retrospective cohort. They had done a large multi-center trial of automated whole breast ultrasound. And the women who had breast density category 1 and 2 were not offered whole breast ultrasound, but women with dense breast tissue category 3 and 4 were. And the interval cancer rate was almost identical. Women who had the fattier breasts but didn't have ultrasound had 1 interval cancer per 1,000 negative screens, and women with denser breasts who did have automated whole breast ultrasound had 1.1 interval cancers per 1,000 negative screens. So all their interval cancers were early stage, almost all were node negative, and the screening sensitivity was increased in the group that had the automated breast ultrasound, even though they were the denser breasts. So 84% in the fatty breast that didn't get ultrasound and 87% in the denser breast that did. So including ultrasound as an adjunctive screening in women with dense breasts brings the interval cancer rate to similar levels as interval cancers in non-dense breasts. So let's just have a quick look at elastography. It's a method for measuring stiffness in breast tissue, and we know when we palpate a cancer we expect it to feel harder than a benign lump, and that's what elastography does using ultrasound. And the goal is to improve specificity of ultrasound given that 80% of biopsies in the US are benign. And the term stress is used to describe the force applied to a lesion. The strain is how much it deforms when you're pressing on it, and Young's modulus is the ratio. How much stress do you need to produce strain? And we expect that tissue compressibility will be decreased in hard masses. There are 2 kinds of elastography available, strain and shear wave. Think of this as the piece of fruit in the jello. You press on the jello, and is that piece of fruit going to spread out or not, depending on whether it's hard or soft. Strain elastography, the tissue motion is in the direction of the ultrasound wave, and the echoes are scattered and used to create standard ultrasound images. It requires gentle compression, either externally, just vibrating the probe slightly with your hand, or sometimes just cardiac and respiratory motion. But you cannot scan with the elastography on when you're using strain elastography. And we read the elastogram by evaluating the size of the lesion, comparing it with the B mode. We can also use a color scale, and we can use the stiffness compared to fat. So here's a case from Dr. Destunis, pretty obvious cancer in that breast. Here's the cancer on B-mode ultrasound, and you can see on the elastogram it looks much bigger. Similarly, a benign lesion in a young woman, typical fibroadenoma, and on the elastogram it actually looks slightly smaller. You can use elastography in that manner to distinguish a fat lobule from a benign solid mass or a complicated cyst from a fibroadenoma, and in a lesion that you're going to biopsy, you might use it to help you decide where to biopsy. Another way of reading elastography is using a color scale. And in some of the vendors, the artifacts turn out to be really helpful because a cyst causes what's called a bullseye artifact. Now, none of us needs an elastogram to tell us that this is a simple cyst, or this one either. There's that bullseye artifact. But what about this lesion? Hypoechoic, it's kind of round. You know, I certainly wouldn't call it a cyst based on this conventional ultrasound, but this one shows that bullseye artifact and indeed turned out to be a cyst. Shear wave elastography, the pulse is generated actually by the ultrasound probe, and the tissue motion is perpendicular to the ultrasound beam. Donna Pleccia, and that unlike strain, you can actually scan with the shear wave on. And in doing so, Dr. Pleccia showed that you could increase the detection of cancer on second look ultrasound after MRI. They looked at how many cancers they found on second look ultrasound and found that out of the 21 cancers they found, 5 of them, they found a third more cancers with elastography than with ultrasound alone. So the malignant features would be increased stiffness, increased size, and patterns of stiffness. And you've got to be really careful with elastography because different vendors use different color schemes. In some machines, red is hard, in others, blue is hard. So you've got to pay particular attention to that. Here's a benign lesion where on this machine red is hard, and you can see it's all soft and it's the same size it was on the conventional. Shear waves don't propagate through all tissue though, so if you're going to start using it, you have to be aware of that. And although cancers typically are harder than benign lesions, there is overlap, and there have been a couple of published studies that showed that even with what would be called softer masses, there can be a malignancy rate. So you would never put all your faith in the elastogram. Limitations, again, operator dependent, no uniformity of color coding, and some systems red is bad and others blue is bad. I think I'll stop there because I've reached my time.
All right, I'm going to bring us home. Let's see, while this gets set. Okay, while we go through the preliminaries, let me just say, first of all, I'm Jay Baker from Duke, and I've been asked to remind everybody to please fill out your evaluations, and also to let you know that the speakers will be available for at least a few minutes after the talks to answer any questions if you want to come forward after the talks, and we'll be happy to answer questions. All right, I'm going to try to bring us home. We've gone through how to detect cancers in various ways, and now we're going to talk about a specific subtype of breast lesion, the probably benign lesion. And you can see I've titled this Probably Benign Rules of the Game, and I've done that specifically because I'll just let you in on a little secret of dedicated breast imagers. Dedicated breast imagers are rule followers. Pretty much all of us are rule followers. We like to know exactly what we can and can't do when working up breast lesions. And in fact, when we see someone or something not following those rules, it makes us downright nervous. So we're going to spend the rest of this talk talking about the rules for one specific subcategory, one specific final assessment category, the probably benign lesion. And the outline is pretty simple. We're going to talk about probably benign lesions as they pertain to mammography, ultrasound, and MRI, starting with mammography. So there's a long history, over 30-year history, of protocols put forth to determine what's probably benign on mammogram. But much of what I'm going to discuss regarding mammography will really be come from the studies of Ed Sickles, 5 studies in the journal Radiology that really lay out the course for probably benign as it relates to mammography. So in some sense, his studies really provide us with the rules. So there are essentially 4 categories of probably benign lesions on mammography: calcifications, masses, what he initially called focal asymmetric densities, what we today would call focal asymmetries, and a small miscellaneous category. So let's start off with the probably benign calcifications. In order to call a group of calcifications probably benign, it needs to be a group of at least 5 calcifications in a cc of tissue. All of those calcium particles need to be round or oval. There's really no BI-RADS category for oval, but that's how they were defined back in 1991. So all the calcifications need to be round. And importantly, those calcifications have to be evaluated on a spot compression magnification view in order to know for sure that they are round. So even though we have electronic zoom on our PAC systems today, that is not sufficient. It has to be a spot compression magnification view. And because it has to be on a spot mag view, you know that you cannot call probably benign off of screening, because you need to call those patients back and get the magnification view. Also, we cannot call probably benign calcifications if the calcifications are new or increasing in number. So what if you see the same group of calcifications like these? They look benign, but they are new or increasing. The rules tell us those calcifications need a biopsy. And to drive that point home, I have 4 cases, so hopefully you can see these, 4 groups of round calcifications. So what do we do? If this is the patient's first screening mammogram, what do we do when we see these calcifications? So you can't call them probably benign off screening. You have to call her back, get that spot compression magnification view, and if they look like this on the spot compression magnification view, only then can you call these probably benign and bring her back in 6 months. But what if you find old films on these patients? These are 4 separate patients. What if you find old films and you realize that these calcifications are new or increasing? Same calcifications, they look exactly the same. In that circumstance, you turn to the rule book, and the rule book is very clear. If these calcifications are new or increasing, those same calcifications need a biopsy. And I can tell you, in each of these 4 circumstances, these were new or increasing. So I think this is very difficult for breast imagers and general radiologists to look at and pull the trigger and biopsy these, because they look so benign. We think we can look at these and tell that they are benign. So the question is, can you tell? I've numbered these 1 through 4. There's no keypad. This is just in your own mind. Pick the one that you think is different than the other 3. Take a moment to look at them. Which one is different? Each of these was new or increasing. There you go. It was number 4 that was different, but not the way you think. So number 4 was the benign. 1, 2, and 3 were DCIS. Now, I'm not trying to tell you that 3 out of 4 cases of round calcifications will be DCIS. That's not the case. Very few of them will be DCIS, but the point is you cannot tell by looking at them. If they are new or increasing, they need a biopsy. This is one of those times when you see new or increasing round calcifications, I try to turn off my brain, I try not to overthink it, and I try to simply follow the rules. All right, let's move on to probably benign masses. In order to call a mass probably benign, its shape needs to be round or oval or gently lobulated. The margins need to be circumscribed. So what does it mean to be circumscribed? That means at least 75% of the margin must be circumscribed. The rest of the margins can be obscured, but nothing else. That means none of the margin can be indistinct, none of it can be microlobulated, and certainly none of it can be spiculated. So here's a case that at first glance looks like a typical probably benign lesion. It looks oval, and at first glance it looks circumscribed. And certainly maybe half of the margins are circumscribed. But if you look closely, you can see that the rest of the margins are actually indistinct. And so no surprise that this turns out to be an invasive ductal carcinoma. In order to call a mass probably benign, it has to be a solid mass. So Dr. Sickles specifically excluded cysts from the probably benign category. So if it's a simple cyst, that's not probably benign. In order to know whether it's a solid mass, of course, you need to do an ultrasound. So all of these patients get an ultrasound. So again, if they need an ultrasound, you know that you can't call probably benign masses off the screening mammogram, because all those patients need to come back for an ultrasound so that you can eliminate the simple cysts. Patients with simple cysts don't need to come back in 6 months. You can simply call those benign and move on. If they meet all the criteria for a probably benign mass, essentially if it looks like a fibroadenoma and there are no prior studies and you're going to follow it, know that about 1.4% of those will turn out to be malignant. Now, I have 1.8% in parentheses. That was actually the initial number on Dr. Sickles' initial study. 1.8% were malignant. That's where that whole less than 2% threshold comes from. But in subsequent studies, he was actually able to downgrade that to 1.4%. So there are a whole list of exclusion criteria of things that we would exclude from calling things probably benign. So these are lesions that are not probably benign. So Dr. Sickles specifically said non-palpable lesions should not be called probably benign. Now you can see I've got a couple of asterisks up there, and that's because in more up-to-date studies we've sort of revisited that, and I'll get into that in the ultrasound section. But certainly these masses can be, should be not new and not enlarging. They should be non-calcified, and they should be not suspicious at ultrasound. So even if it looks oval and circumscribed on mammogram, if there's a suspicious feature on ultrasound, that mass needs a biopsy. So as in this case, where it's partially solid and partially cystic, no matter how benign looking it is on mammogram, that needs a biopsy. But also recognize that size and patient age are not relevant to determining probably benign. All right, moving on from calcifications and masses to focal asymmetries. So a focal asymmetry, as we've already discussed, is an asymmetric area of fibroglandular density. It's a discrete opacity that you can see on two orthogonal views. So you can see it here on the MLO view, and there it is on the CC view. So that's a focal asymmetry. It has concave outward margins, interspersed fat. Again, there are no size limitations when it comes to following a focal asymmetry as long as it meets all the rules for probably benign. So what are those rules? When it comes to a focal asymmetry, the focal asymmetry must be non-palpable. We can't follow palpable focal asymmetries. There should be no associated microcalcifications, certainly no associated architectural distortion, and critically, the focal asymmetry should be not visible on ultrasound. That's a critical test. So all of these patients in whom you see a focal asymmetry on screening and then on subsequent diagnostic workup need an ultrasound. So here's an example of a small focal asymmetry in the medial breast. This would be something that if it was not palpable and you had no prior mammograms, could be put in the probably benign category until you do the ultrasound. And on the ultrasound you can see she has a slightly taller than wide, hypoechoic, ill-defined mass. That needs a biopsy, and that turns out to be malignant. There's also a small miscellaneous category of lesions that can be called probably benign on mammogram. There's the single dilated duct without nipple discharge. Again, these patients we would bring back for an ultrasound, and you would expect to see a nice anechoic duct. As long as you do not see an intraductal mass, those cases can be followed in 6 months as well. And finally, calcifications that are suggestive of early fat necrosis, a little bit difficult to see, but there's a bit of a lucent lesion there with some calcifications that are beginning to look like rim calcifications in an area where the patient received some trauma. If you believe those are going to be early fat necrosis, that can be brought back as probably benign as well. So what's the workup? We've talked about these four categories. What would be the workup to know whether you can bring these patients back and call them probably benign? The first most important part of the workup for declaring a lesion probably benign is obtaining all old films for comparison. I can't stress that enough. If you do nothing else, the most important thing you do is try to get all old films. And the reason is, if you're able to get old films, that essentially takes probably benign off the table. If you get old films, you'll know that the lesion is stable and therefore benign, or you will know that it is new or increasing and therefore suspicious and needs a biopsy. So that's the first most important thing. Assuming there are no old films, that's the patient's first exam, these patients need a full diagnostic workup regardless of the finding, whether it's mass, calcifications, focal asymmetry. They all deserve a spot compression magnification view and in appropriate circumstances ultrasound. And so I really want to emphasize that we would never use BI-RADS 3, never call something probably benign off screening mammogram alone. What's the protocol for following them? You've decided to put the case in a probably benign category. We would generally bring those patients back for a 6-month follow-up from the date of the original exam, and then a bilateral exam 12 months from the date of the original exam, 24 and 36 months from the date of the original exam. That at least is what the original protocol was. I can tell you that at many facilities, mine included, we would generally stop after 2 years of follow-up when the lesion is still stable. And just a little newsflash, I can tell you that in the new BI-RADS manual that's coming out at the end of this year, hopefully, they've actually made it official that you can do either a 2 or 3 year follow-up when dealing with a probably benign lesion. So this is another little hard-won piece of information from a really difficult experience. If you are tempted, sometimes you're tempted to bring back a lesion a little bit earlier than 6 months. So you see a lesion, you think, it's probably benign, I'm going to bring that back. But you know, there's something about it, I don't want to wait a full 6 months, I'm going to bring it back in 3 months or 4 months. If you are tempted to bring back a lesion in less than 6 months, there's something about that lesion that's tipping you off that it is more suspicious than you think it is, and I would suggest that is a time to consider a biopsy. We've been burned in the past by those cases. There are some exceptions. There are things that you would expect to evolve faster than 6 months, and you don't have to wait 6 months to follow these things up. Seeing an abscess resolve, you want to see fat necrosis fully evolve, you want to see resolution of a hematoma, or perhaps you want to see a small lymph node regress. These are things that you do not need to wait 6 months for, and you can in fact bring them back in as little as 6 weeks to 3 months, depending. When in this protocol, when in the follow-up, would you choose to finally pull the trigger and actually do a biopsy? If you see any increase in size in the lesion or increase in number of calcifications, it is important, even if it otherwise still looks probably benign, if it is growing, it needs a biopsy. And that can be just a couple of millimeters of growth. If you think that growth is real and not just a difference in measurement technique, if you think there's any real growth, I would urge you to stop following the lesion, no matter how benign it looks at that point, pull the trigger and do a biopsy. And certainly if there's any suspicious change in morphology, so you were following something, it was circumscribed, you bring it back in 6 months or a year later, and now it's more indistinctly marginated, that needs a biopsy as well. This may be one of the most important slides of the entire talk. So instead of talking about what is probably benign, I want to spend a minute about talking about what is not probably benign. So these are all things that we've all seen called probably benign that don't technically that don't really fall into the category, should not be used as probably benign. The first is the patient who is dense but normal. So extremely dense breast, otherwise normal mammogram, but you know that could be hiding a Mack truck in there and you're nervous about it, so you want to bring her back in 6 months. And your report reads, normal mammogram, but recommend 6-month follow-up because patient is dense. There's no evidence in the medical literature that suggests that we are doing these patients any favors by bringing them back in 6 months when they have an otherwise normal mammogram, even if they have dense breast tissue. How about the patient who has normal imaging but a strong family history? Again, nothing in the medical literature suggests that we are helping these patients by asking them to come back in 6 months just because they are high risk, as long as their mammogram is normal. We're not decreasing mortality by doing that. Again, we would not want to use probably benign BI-RADS 3 off a screening exam. In fact, the ACR manual itself says all the published studies emphasize the need to conduct a complete diagnostic imaging evaluation of probably benign lesions. Hence, it is inadvisable to render such an assessment when interpreting screening mammograms. So there it is in black and white, not off screening. If that's not enough, there's actually financial incentive not to use BI-RADS 3 off screening. There's a Medicare incentive program called PQRS, and one of the metrics that they have instituted is how often do you call probably benign off a screening mammogram, and their threshold is 0. That is, they expect there to be no times when you're using probably benign off screening. When else should we not use probably benign? When it's a benign lesion. So if it's a BI-RADS 2 lesion, if it's typically benign, if it's a fat-containing lesion like this hamartoma, or lucent-centered calcifications like the case below, if it's a simple cyst, we should be able to call that definitively benign, BI-RADS 2, and bring her back in a year. It's really in some ways not fair to the patient to waffle over those and call them probably benign when there's imaging evidence that justifies calling them benign. Similarly, multiple bilateral masses, multiple bilateral calcifications were initially included in the probably benign category in the study from 1991, but subsequent studies have shown that these patients are not at increased risk of cancer, that we are not missing more cancers in these patients, and so we can legitimately call these patients BI-RADS 2 benign. When else should we not use probably benign? If there is imaging evidence of interval change, so you get old films, the patient's had prior studies, and the lesion is new or increasing. Again, from the BI-RADS manual, evidence from all the published studies indicate the need for biopsy rather than continued follow-up when most probably benign findings increase in size or extent. So again, pretty clear that those are the rules. Another circumstance when we would not want to use probably benign is after a discordant needle biopsy. So you're doing a stereotactic biopsy and you fail to get sufficient calcifications. Or you are biopsying a fairly suspicious mass, let's say a spiculated mass, and you get back fibrocystic change. You get back a discordant result. It is not a reasonable substitute to put those patients in a 6-month follow-up category. We need to rebiopsy that or send those patients on for surgical excision. And finally, palpable lump, which just want to caution that you be very careful when choosing to follow something that is palpable. In general, we wouldn't, but I'm going to get into that more in the ultrasound category, which is right now. All right, so in the ultrasound category, which lesions can we call probably benign by ultrasound? I just want to answer 2 questions. First, can I follow a mass that's visible only on ultrasound? And can I follow a mass that is palpable? We'll start off with the first. How about masses that are visible on ultrasound only? This is more common now that we're doing screening ultrasound more frequently. It also comes up that you're looking for something else, and you trip on a lesion the patient wasn't feeling and that you did not see on mammogram. So Dr. Graf and Dr. Sickles together in a study from Radiology 2007 looked at about 450 non-palpable masses, that's key, non-palpable masses, all of which were either not visible at all on the mammogram or were largely obscured on the mammogram. At ultrasound, they looked like typical fibroadenomas. They were all oval or lobulated, they were all circumscribed, they were isoechoic or mildly hypoechoic, and they were wider than tall, parallel orientation, and of course no acoustic shadowing. So of the 450, how many of those turned out to be malignant? 1. So 1 out of the 450, that's a negative predictive value of 99.8%, certainly well less than the 2% likelihood for things that we're comfortable calling probably benign. So, can I follow a mass that's visible on ultrasound only? If it meets all of those criteria and looks like a typical fibroadenoma, yes, that's safe to do. How about, can I follow a mass that is palpable? Okay, there are 2 primary studies on this. Again, the team of Dr. Graf and Sickles, and a second study by Jennifer Harvey in 2009. Both groups looked at ultrasound of round, oval, or lobulated masses, again circumscribed, again wider than tall, essentially masses that look like typical fibroadenomas at ultrasound. And here are the results. To combined, over 500 cases, 1 cancer. So again, negative predictive value in the 99.8% range. So can I follow a mass that is palpable? Again, if it meets all those rules, looks like a typical fibroadenoma, the answer is yes. But I would, this is one area where I would urge you to be very, very cautious. Because remember, if the patient says, I feel a lump today, and by the way, I didn't feel it 2 months ago, that suggests growth. That suggests the mass is growing, and really want to be ultra cautious with a growing solid mass. In particular, for patients who are genetic carriers, you need to know that their cancers, the cancers of women who are genetic carriers, can more often look like fibroadenomas. So in general, if I saw a mass that looked like a fibroadenoma on a genetic carrier, I am not going to follow that mass. For all women who you may be considering following a palpable mass, you have to insist on 100% sharp margins. The answer often is in the margins, and it really should be 100% sharp. This one is just sort of my opinion. In my experience, the plumper the mass, even if it looks oval or round, circumscribed, the plumper it gets, the more round the mass gets, the more likely it is to be malignant. For round masses, I personally do not follow those. In my experience, as often as not, those turn out to be malignant. So again, this is one of those times where you simply have to say, follow the rules, and they will keep you out of trouble. All right. We're going to finish up with MRI, and I'm going to ask and answer 4 key questions for MRI. Which MRI lesions can I follow? What is the timing for follow-up? What % of MR cases are probably benign? And what % of those should I expect to be malignant? Starting with which MRI lesions can I follow? And I hate to tell you this, but when it comes to MRI, there are no rules when it comes to what lesions are safe to call probably benign. That's the take-home message when it comes to MRI. And I got to tell you, that makes us nervous. And the reason there are no rules, like there are for mammograms, is because there are no studies that were done in the same ways that the mammogram studies were done. So Dr. Sickles, in his studies, basically followed all clusters of round calcifications. He followed all single masses that were circumscribed in oval. But that's not how the MR studies have been done. They didn't follow all lesions with specific features. Those studies were done saying basically of the lesions that we followed, this percent turned out to be malignant. There may be many more that they didn't follow that were benign. There may have been many others that they didn't follow because they chose to biopsy them. But those aren't necessarily included in the study. So we don't have a denominator of all studies. We just have a denominator of studies that they chose to follow. So you can't go home and know exactly how to translate those studies into your own practice. Having said that, there are generally three types of lesions that people will tend to follow on MRI: the enhancing focus, areas of non-mass enhancement, and round or oval circumscribed masses. So let's take a look at these, starting with the enhancing focus. So an enhancing focus on MR is basically a dot of enhancement less than 5 millimeters in size. One of the first studies on the focus was done by Dr. Lieberman in her provocatively titled article, Does Size Matter?, where she looked at 37 foci that they biopsied. Again, they didn't biopsy all foci. These were just the 37 that they biopsied for one reason or another. So 37 foci that were biopsied, one of which was malignant at about 2.7%. So that's right in that 2% range that we accept for probably benign lesions. And most people would accept slightly higher than 2% for MRI. Recognize that this study was done without the benefit of kinetics, but Dr. Eby, in a subsequent study, larger study of 168 foci, did look at kinetics. He found one malignant lesion among the foci that they studied, and that one happened to have washout kinetics. Of the almost 70 foci that had persistent kinetics, there were no cancers. So kinetics may be helpful when it comes to evaluating the focus. How about non-mass enhancement? So non-mass enhancement is actually a really difficult area to know what to do with when it comes to probably benign. Dr. Eby's is one of the largest studies where he looked at the morphology and kinetics of 115 areas of non-mass enhancement, one of which turned out to be DCIS, so that's certainly well less than our 2% threshold. But if you're wondering, can I follow non-mass enhancement, or which non-mass enhancement can I follow in my practice? The answer is in this chart, and the answer is I don't know, because the descriptions are all over the map. So these are the foci, or the areas of non-mass enhancement that they followed. So the distributions were 30% focal, 25% diffuse, 17% regional. The enhancement patterns range from heterogeneous to clumped to homogeneous, and the kinetics were mostly persistent, but plenty were washout and plateau as well. Size overall was about 2.5 centimeters, but ranged from 3 millimeters to 10 centimeters in size. There's no way to take those data and apply it to your own practice to know what is safe to follow and what isn't. So you're faced with a case like this, a typical case, right? Patient has implants and an area of non-mass enhancement on the right. Follow it along. It's persistent kinetics. Is that safe to follow? You hope so, because you don't want to biopsy her with those implants in place, but there's no data to know for sure how safe it is to follow that sort of area of non-mass enhancement. When evaluating MR, another area that, another type of lesion that tends to get followed is the probably benign mass. Importantly, just like everything else we do, you want to compare with other imaging modalities. So even if it's the patient's first MRI, remember to compare back with her mammogram and any prior ultrasounds. So here's a mass that would be often followed. Again, no great data to support it, but often followed because it looks like a typical fibroadenoma. It's oval and circumscribed and homogeneously enhancing. Put that in the 6-month follow-up category. Is that safe to do? Probably, but nobody knows for sure. However, in this case, if you do the correct comparison and look at her mammogram, you can see that she has that mass present. She has multiple prior mammograms showing that mass is stable, and so she doesn't need to be followed at all. So important to compare with prior mammograms. For masses that you're considering following on MRI, generally the ones we would consider following would be round or oval in shape, circumscribed margins, and persistent kinetics. So here's a nice oval, maybe slightly lobulated circumscribed mass. that has a persistent enhancement pattern that is probably safe to follow. I say probably safe because nobody knows the numbers on what percent of these will turn out to be malignant. We know that number is low, but we don't know exactly how low because the study simply hasn't been done. It also depends in large part on your clinical scenario. So you can follow things off a screening MRI. It is much harder to follow things on a patient who is undergoing preoperative planning. She's about to get surgery, she's about to get chemotherapy and radiation. By and large, we would not follow anything in patients undergoing preoperative MRI because they need an answer now in order to plan intervention. All right, so which MRI lesions can I follow? Probably enhancing focus with persistent kinetics. Non-mass enhancement, it is unclear which ones are safe to follow and which aren't. And masses that are round or oval, circumscribed with persistent kinetics are probably safe to follow, but I have no data to share with you on how safe that is. Remember, when it comes to MRI, there are no rules. All right. What is the timing for follow-up? So again, no rules, right? This really hasn't been studied, but most people would follow the typical follow-up protocol for mammography, 6-month follow-up MRI, then a 12-month from the initial date of her first MRI, then 24-month follow-up after that, looking for stability over that time period. Is it possible that a shorter follow-up would work just as well? In certain circumstances, perhaps. In many cases of non-mass enhancement, particularly for patients who are premenopausal, we might suspect that they have physiologic enhancement. In some cases, that'll be gone in 6 weeks. And so you don't necessarily have to wait 6 months. I would be very hesitant to wait 6 months to follow something that looks like this. Might bring her back in 6 weeks to see if it was physiologic enhancement, gone in a different phase of her cycle, but I certainly wouldn't wait 6 months on something that looked like that. All right, and finally, we're going to discuss what percent of MRI cases would I expect to be probably benign, and what percent of those will turn out to be malignant. So there are a number of studies that have reported on the frequency of probably benign in their cohorts. They range from about 6.5% all the way up to 1/3 of the cases were called probably benign. What percent of those turned out to be malignant? Anywhere from 0% up to 10% turned out of the probably benigns turned out to be malignant. Now recognize in one of the studies from 2005 that showed 6% were malignant, that was really a problem-solving cohort. So you'd expect a higher frequency of malignancy in that cohort. And in a study from 2003, it was quite an early study, it was really one of the first, 10% frequency of malignancy, really a bit of an outlier, we would not expect that today. If you look, most of the data is in that 0 to 2.5% range that we expect for probably benign lesions. So it's actually not much higher for MRI than it is for mammogram or ultrasound. But recognize that your results may vary depending on your patient population, whether you're looking at high-risk screening or problem-solving populations or preoperative planning, and certainly whether the patient has had prior MRIs. So in a study by Dr. Kuhl, in the first round of MRI screening, they found 18% of cases were probably benign. In the second round, only 7%. And in another study, went from about 7.5% down to 3%, down to 2.5%. So when you have prior MRIs, you expect fewer and fewer probably benign lesions. It also depends on your MR biopsy experience. The more comfortable you are with MR biopsy, the less likely you're going to feel compelled to call something probably benign. You're more likely to feel comfortable just sticking a needle in it. Will patients comply? Will they come back for the MRI? The studies have shown that between 62 and 86% of patients will come back for the follow-up MRI, and that's almost identical to what we find with mammography. So as often as they come back for mammography, that's how often they'll come back for MRI. All right. So by way of summation and conclusion, for mammography and ultrasound, there are specific rules for probably benign. I would urge you to learn those rules and follow those rules closely. They will keep you safe and keep patients safe. But for MRI, unfortunately, there are no definitive rules. The best we can do is track our own data. Track your data, make sure you're comfortable with where you're at, make sure you're comfortable with what percent of your cases are probably benign and what percent of those are malignant, and most of all, be careful. All right, I thank you all very much for your attention.